Pressure ulcers, surgical management. Some pressure ulcers warrant surgical intervention, specifically stage 3 and stage 4 pressure ulcers. This is especially true of those pressure ulcers not closing by conservative management or those requiring quick closure. These particular pressure ulcers require a referral for surgical closure consideration. Surgical intervention requires preoperative considerations, wound bed preparation, and identification of the appropriate procedure. Procedures which may be performed include skin grafts and flaps. It is the surgical management of pressure ulcers which will be explored in this presentation. By the end of the presentation, one should be able to describe pre-operative considerations and wound bed preparation, explain the reconstructive selection process, and identify types of surgical closure flaps. Also describe the post-operative management options. As with any surgical procedure, the benefits and risks of the procedure must be considered. For example, will the individual be able to survive and recover from the procedure? Will the necessary post-operative management needs be met? Consideration should also be given to any comorbidities. For example, in the case of diabetes, hyperglycemia, of course, will delay wound healing. The individual then should have their comorbid or chronic diseases properly managed to enhance their ability to heal. Other factors to consider are malnutrition and perfusion. Individuals who smoke should be encouraged to quit. Nicotine is known to have a negative impact on tissue perfusion because of the vasoconstrictive properties. Frictional damage may occur. This can be particularly a problem in neurologic or paralyzed conditions. Hence, the individual experiences spasms. The spasms need to be controlled prior to surgery. Fecal and urinary incontinence also require intervention. Many times an indwelling catheter may need to be placed to prevent contamination of the surgical site while it's healing. Likewise, fecal incontinence may need to be managed with a pouching system or fecal management system. In some cases, a temporary colostomy may need to be performed. Post-operative management considerations include the individual's ability to be compliant and their available support system. Does the individual have financial resources for such things as wound care dressings and physician visits? Is there a support system which will encourage self-care and encourage the individual to follow post-operative care instructions? Is this support system willing to assist with such things as dressing changes and transportation to appointments? Consideration should be given to the post-hospitalization environment. In many instances, a specialty mattress or bed will be required. Is the environment then safe for the individual to return, or do adjustment needs to be made? Pressure redistribution chair cushions will also be necessary. Once it is determined the benefits outweigh the risks, attention should be given to the wound bed preparation. Successful surgical closure requires a clean wound bed free of infection and free of necrotic tissue. Surgical debridements may then be required to achieve this clean wound bed. A course of antibiotics may also need to be administered. Once the wound bed is prepared and the individual is deemed to be a surgical candidate, consideration is given to the type of closure to be performed. A reconstructive ladder is often used to assist in this decision-making process. The ladder progresses from least complex procedures to more complex ones, and procedures include secondary healing, linear closure, skin graft, skin flap, muscle flap, skin muscle flap, bone tendon nerve flap, skin muscle bone flap, and skin muscle free flap. Procedure selection is dependent upon the goal of treatment and the individual's decision. Both skin coverage and soft tissue coverage may be achieved through surgical management. Skin grafts provide superficial coverage and therefore are used more on donor sites. Rarely then are skin grafts used as a surgical option for pressure ulcers. Skin grafts has been used in burn management as well as on venous ulcers. There are basically two types of skin grafts: split thickness, and full thickness. Split thickness skin grafts may be applied in a manner conducive to allow wound exudate to drain and allow for contouring to the skin. Flaps include their own blood supply. Skin as well as underlying structures are also transferred with the flap. Underlying structures may include subcutaneous tissue and muscle. So flaps then fill dead space as well as provide padding to the defect, allowing for pressure resistance once healed. Additionally, a physiological barrier to infection is achieved when the flap includes the muscle. Flaps may be categorized as local or free flaps. Local flaps may be classified by the anatomical structures involved, the method used to move the flap, and the method of retaining perfusion. Each of these classifications can be further subclassified. Classification of anatomical structure flaps includes skin flaps, fasciocutaneous or myocutaneous, or musculocutaneous flaps. Like skin flaps, or like skin grafts, the skin flap is not often used for pressure ulcers related to their limited blood supply and protection. Fasciocutaneous flaps, on the other hand, do provide padding and protection as well as superficial coverage. Optimal coverage is provided by the musculocutaneous flap, and as a result are most often the flap of choice for pressure ulcers and full-thickness wounds. Advancement flap, rotation flap, and transposition flaps are subclassifications of removal methods. Classifications of methods of retaining perfusion include the random flap and the axial flap. The most complex method of wound closure is the free flap. It is considered after all other options have been exhausted. Free flaps are the muscle flap containing veins and arteries. These vessels are disconnected at the donor site, then reconnected at the recipient site. Postoperative management impacts the success and survival rate of grafts and flaps. Revascularization of a graft is dependent upon graft's mobility, with inadequate immobilization resulting in skin graft failure. Revascularization can be impeded by edema in the wound bed. Measures, therefore, should be taken to control or reduce this edema. One method is site elevation. Another possible measure is negative pressure wound therapy. It is believed that negative pressure wound therapy both aids in edema control and promotion of graft adherence. Infection is another possible complication. Graft sites require lifelong protection and moisturizing related to sweat and oil glands not being transferred with the graft. Dryness, pruritus, dermatitis, and folliculitis are all common complaints. Donor sites also require care. Those sites require protection as the healing process occurs. Wound dressings of transparent films and ointment-impregnated dressings such as Xeroform and Vaseline gauze. Pressure redistribution and shear prevention are the main focus of postoperative care for the flaps. Interventions aimed at pressure redistribution and shear prevention include the use of specialty beds and turning sheets or comparable systems. Education should be focused on pressure ulcer development and prevention, including pressure redistribution and shear prevention. Gradually, pressure and shear exposure is reintroduced to the affected area. Pressure redistribution chair cushions should be utilized. Potential complications associated with flaps include infection, hematoma, suture line separation, flap necrosis, and pressure ulcer reoccurrence. When surgical intervention is identified as the treatment of choice for a pressure ulcer, careful consideration should be given to the wound bed preparation. The procedure to be performed is determined using reconstructive selection process. Postoperative management is guided by the type of procedure performed and is impacted by the person's ability to be compliant with all aspects of care. However, a positive outcome can be achieved. This ends our module on pressure ulcer surgical management. Thank you for your attention.